Okay, hello everyone. Good morning for the speakers that we have today. Good afternoon for some of you. Good evening for people in Asia. So welcome to the second day of this IRCAD session focused on the management of hiatal hernias. Yesterday, we had a chance to have a very good speaker, very good discussion. A lot of people were connected. So very productive session. But I'm pretty sure that today we can do even better because we have a very brilliant faculty. Not me, of course, but we have people very well known in the field from the United States. And by chance, I was just discussing with Silvana. Today, we have two ex-president of SAGES. We have John Hunter, who is connected with us, and in the studio we have Lee Swanström, so very prestigious, and of course Blair is well known everywhere. But he was not, if I'm right, you were not president of SAGES yet. So we will cover again the topics related to hernias and really focusing more on paraesophageal hernia, addressing some issues that were initiated yesterday, like people were asking questions about mesh, diaphragm, crural repair, etc. So this is a topic that Blair will address. I will talk a little bit about the way we're managing recurrence after this primary repair. And of course, John will finish this session talking about the potential complication that we have when we manage this sort of quite frequent problem, in fact. So I leave the ground to Lee for the introduction of Blair. Thank you, Lee.
Okay, thank you, Bernard, and welcome to the audience, but a particular welcome to my two good friends, John and Blair. Blair Jobe, I had the fortune of working with many, many years ago as a brilliant fellow, and he's gone on to do great things, so I'm always very proud of him. He's at Allegheny General in Philadelphia, and is doing great things. A foregut surgeon, does a lot of basic science research and some innovative developments in minimally invasive surgery in general, but foregut's always been his passion, and the esophagus is kind of his greatest love. So Blair, we're looking forward to hearing you talk about what happens when you can't close the hiatus.
Can you guys hear me okay?
Yeah, sure.
Oh, great. Okay, thank you, Lee. Bernard, Silvana, thank you so much for having me. And I was able to log on yesterday, and I thought the talks were fantastic, and hopefully I can contribute equally to the good course that you guys are putting on here. So I think we've all been in this situation where we can't get the hiatus closed. But before we get there, I just wanted to give Bernard an update on his named lectureship, which we established here in Pittsburgh. And you can see that the people on here are well known, and this has become our annual lectureship. That's our big deal every year, and we have a big dinner and lots of other discussions and stimulating things in the OR and doing cases. And there's just one name missing from here, but he's been proven to be elusive. But I plan to nail down John at the end of this talk to get him signed up. So anyway, Bernard, it's going well.
Blair, show me the screen. Share your screen on that. I want to see that.
We can't see your screen yet.
Because I was looking at that. I'm following that.
So unfortunately, we had to cancel this year. How do I share my screen? Are you guys not able to see it?
Not yet.
Not yet. On the top of the screen?
Bottom of the screen.
Share screen in green.
Share screen.
The green button.
Okay, hang on.
You see, all the best foregut surgeons in the world are not really comfortable yet with technology.
I'm a disaster. I have a bad case of learned helplessness.
We have a list of the wars. You're not there yet.
Does that work?
Not yet.
Not yet.
You should have a green arrow at the bottom of your screen.
Yeah, I'm pushing it.
Yeah, and then you can choose PowerPoint.
Oh, I see. Okay, I got it.
So not only this is a course on hiatal
something
hernia,
happens.
yes, it's also a course on how to use this
So-
system.
The new reality.
Thanks,
Oh.
guys.
Wow,
Okay.
wow,
Looks
impressive.
nice.
Mhm. Yeah, so it's happening, but we've been really, really proud of this, and obviously no one has matched up to Bernard, but you know they're trying. I think Lee did.
Very nice. I enjoyed. Thank you so much.
Right.
Thank you.
So as you guys all know, you know, if you just look at this image on the right, you know, this is why we can spend a whole career trying to improve outcomes in this field, just because there's so many different forces that are opposing and placed on this enigma, the gastroesophageal junction. And as was so elegantly covered yesterday, you know, axial tension is probably the easy part for us, right? We can do lengthening procedures and mediastinal mobilization, and we can lift the vagus nerves off the GE junction to untether it. And there's all sorts of things we can do to increase axial length. But I think the real problem that we encounter is in radial tension, and that's, you know, between the diaphragm and crural pillars. And you know, oftentimes, you know, you'll see a patient that comes into surgery who doesn't have a diagnosis of hiatal hernia, and you go in there and you see that the crural pillars are just completely widened, and you have a taut phrenoesophageal ligament from the CO2 pneumoperitoneum that looks like a trampoline, and you get it opened up and it's just huge. So how do we reduce that radial tension? Well, we try to do it by breaking every surgical principle that we've been taught, which is, you know, we repair under tension, we put muscle to muscle. And unlike ventral hernia, you can't really do a component separation. There's not really, so you know, it really gives the opportunity for a lot of creative thought in this area and to try and improve outcomes. And despite everything that everyone has tried, you know, I think that there's still a unacceptably high recurrence rate. And so I want to talk about that just a little bit. I just show you this because I wanted you, this is from Seattle, but this shows a tensometer, and they put a suture on the left cruce and then the tensometer on the right, and then they draw them together and can, you know, actually directly measure or put an objective number. And the reason why I showed you that is I just wanted to show you the different types of hiatuses that we all encounter. And, you know, we all love to see this one right here. Which is the slit. You know, we know we can get that closed. And the teardrops is not a bad one either. It's this one right here, the D, which is the oval. And if you look at, you know, it's not surprising that when you use the tensometer that has the area of most tension. And these are the hardest to get closed adequately, because as you draw these two sides together, you get this funky widened angle here. And there's usually not substantial tissue anteriorly to get a good suture bite into, and to have confidence that you really close that in an acceptable fashion. So what are the options for hiatal closure? Well, we've kind of thrown the whole kitchen sink at everything. So, you know, usually it's primary repair, and we usually can do that. In our group, we use O-ethibond suture. And you can do whatever suturing technique suits you, but there's really no data on how you would suture something or what approach. Now, I was trained with, you know, using pledgets, and I've abandoned that just because oftentimes, you know, not oftentimes, but occasionally you'll see it end up in the lumen of the esophagus, and the thought is maybe it creates a little bit of a fibrotic reaction and bolsters your it's like mini mesh. It kind of bolsters your closure. A whole host of prosthetic closures have been proposed with synthetic meshes, and as was discussed nicely yesterday, is that we would really try to avoid that in the hiatus. And certainly you wouldn't want to bridge a defect like a trampoline going across. And then, you know, it's kind of free field to be able to use you know, biomeshes. As we know, that there's not a lot of data that supports that it's helpful. And then, you know, like any unsolvable problem, people get super creative and try and do anything that they can. And that's just a reflection of the fact that we're not doing well enough. is the falciform ligament buttress. So people try and get creative. So when you're in the operating room, what are the maneuvers you can use to decrease tension to facilitate a primary closure? Well, you can decrease your pneumopressure, and we typically use all of these things. You can create a capnothorax, and we usually do this on the left side. And you just reach up after you've done your mediastinal dissection, grab the pleura, and make a pleurotomy, and drop that lung, and you'll find that the crura comes over substantially. Now the question is, does you do that in the operating room in a paralyzed patient? Once you wake them up, what happens to that tension? And I don't think we know the answer to that question. We can dissect, it's important to dissect the sac, as Silvana showed in her great video, is that, it's really important to get around that GE junction and make sure the sac is well away from everything, so that there's nothing that's occluding or obstructing a primary closure. It's important not to tear up the crura. I've had cases where at the end of the case, the crura is all beat up, and you just don't have confidence in your suture being able to hold over the long term. You can add anterior sutures if the tissue is not attenuated, or you're not just looking at the inferior aspect of the pericardium with nothing there. And then I want to focus a little bit on relaxing incisions, because I think there's value to them. So the sequence of maneuvers, these are kind of my sequence of maneuvers that I use sequentially in the operating room when I see one of those big oval hiatus that's all woody. It feels hard as a rock. It's not mobile. You just put a suture in there and you almost start laughing because it's just not coming together. So the first thing I do is I consider the patient's clinical status and their existing comorbidities. Is this an 85-year-old guy who just can't eat and has tremendous chest pain and just wants to be able to swallow? In that case, I'm just not going to feel that pressured to perform an anti-reflux surgery and do the nice buttoned up, type 3 repair with a nice hiatal closure. I might lean more towards, this gastropexy that we do, and I'll explain a little bit later in the discussion of how we do that, and just straighten out the esophagus and get it into a situation where you're going to prevent reherniation and just enable him or her to be able to eat. The first step that I use is to mobilize the right crus away from the vena cava, and I just do that just with blunt dissection. And once that right crus has come laterally, I'll incise the peritoneum right in line with the vena cava, just to loosen it up. And you'll find that it does come over, quite a bit when you do that maneuver. And, as we all divide the pars flaccid or the gastropatic omentum, a lot of people will stop that mobilization up where it gets thick, anteriorly, just at the very top of the right crus. There's that thick area that kind of keeps it. And I'll just make sure that that's all taken down and nice and smooth there, so that there's nothing pulling from the liver side. The next step is that I'll reduce the insufflation pressure, take it down to about 10. And then from there, if it's still not doable, I'll create a left capnothorax, and that usually solves the problem. Then the posterior crural tension relieving mattress suture is something that we started using that I find helpful to get the closure, and I'll show you exactly what that is. It's not rocket science, but I think it does help. And then finally, as a final maneuver, we'll do the central tendon release with mesh closure of the resultant defect. And then I'll just discuss briefly about bailout maneuvers. So I'm sorry for my childlike drawing here. I'm not that good at doing the artistic component of this, but this is the suture that we use. So if you're looking from the middle of the patient out laterally towards the spleen, this is the right crus here, and then the esophagus coming through the hiatus. This is the abdominal side and the chest side. And what we do is we just take several sutures very deep and do them in a horizontal mattress configuration. And what that does is it brings the crura, starts to bring the crura together and unweight it a little bit, so that then subsequently you can put a suture anteriorly. And I find that that is pretty helpful prior to, that's a maneuver that we use prior to doing the releasing suture. The other thing that we do is when we know that it's going to be difficult to get closed, I'll put in a couple of posterior sutures under tension, and then I'll do my diaphragm releasing suture and see how it's coming down, using that as a way of gauging whether or not you've unweighted that right and left curl primary closure. This is the approach that we use, which is the central tendon release. You'll find that a lot of people, they describe, I hope you can see my arrow here, but a lot of people will describe incising the crura here so that there's an opening, and now you're looking up into that hernia sac. And I never really liked that, because it just is just a little tenuous band of right crus that's kind of holding your repair together. So what we do is we come up, divide the phrenic vein, and then come up and just very carefully, where it fuses with the pericardium, we incise this area after taking down the triangular ligament of the left lateral segment. And as you're doing this, you'll see it pull open into, over on this side, you'll see it pull open into a D configuration, and this right crus will swing over, and it's profound. You know how when you do these procedures, you have that angle. Hopefully you can see my hands, but you'll have that angle where the right crus comes and the arch of the diaphragm. And as you release that, you'll see this angle flatten out and the right crus will come down. And this works very, very well. It leaves a big hole there. And so we close that with synthetic mesh and just suture it into position. This is from Brandt Ulschlager, and this is the typical kind of the right-sided releasing incision along the right crus, which is just dividing the overlining peritoneum. Here's another example of it. But you can still see that big V that's always unsatisfying, and I like this whole area just to come over to the right. And then what Brandt does is then wraps a biomesh around the whole thing. And, you know, I mean, this is definitely an approach. It's not as satisfying to me, but I think, you know, we're all trying to do the best that we can. This is from the Portland group, Steve DeMeester. He does a similar thing where he just opens this ascending part of the diaphragm, leaving a strip of muscle in contact with the esophagus here with a primary closure posteriorly, and then you have this big hole here, and then he closes that hole with PTFE, and then over that PTFE we'll place a biomesh. This is the left side. You know, the left side, you have to be careful of the insertion of the trunk of the phrenic nerve, and he follows the path of the seventh rib, creates an opening here, and then covers that. I really stay away from the left side, and I learned that the hard way, in that, you know, I've done several of those, and a large percentage of them have presented to the ER with a intrathoracic herniation of colon or small bowel, and then we've had to re-repair them. And in one case, we had a guy that recurred twice. So I've kind of abandoned doing relieving incisions from the left side. Let's see here. So again, preferred is the right side. Here's a nice example from Steve. The phrenic nerve kind of trunk, you want to kind of avoid this area, and you would do your incision here just below the seventh rib. Just as an example of tension relief with these maneuvers, this is a nice study, I think, also out of Seattle. But you can see that here's your existing tension at the time of paraesophageal hernia repair, and when one performs a pleurotomy, you get about a 36% decrease in the tension. Okay, that's again sedated, paralyzed patient that's asleep and not breathing. And then when you add a right relaxing incision, you get about a 46% decrease. Okay, and when you combine those two, you get about a 56% decrease they found in existing tension between the crural pillars. Just a minute, I thought this was clever, is just a mobilization of the falciform ligament, and then patching it posteriorly as if it were a biomesh onlay, and that onlay is just over that region where the two pieces of muscle have been primarily closed. We have to mention this study. Initially when this was done, this just tells you, 6-month follow-up in a randomized controlled trial is exciting and interesting, but by far from telling you the whole story. And this was a 4-center prospective randomized trial that's well known. Primary repair versus primary repair with an onlay surge assist. And John and I were working together at the time this was done. I remember enrolling patients into the VA, and we're really excited about this. There was no difference in OR time, complications between the two groups, and at 6-month follow-up, there was a significant reduction in recurrence rate compared to comparing the primary versus the mesh patients. But then flash forward 5 years later, and they were able to track down 60 patients that ultimately got an upper GI. Now, whether or not the 36 patients that were not followed up had intact repairs may have changed these results, but we work with what we have, and so we have 60 patients here, and what they found is there was no difference between primary repair versus primary repair and surge assist onlay. That's the biomesh onlay. And there was no difference in complications or reoperation rates in that group. So the overall conclusion was that surge assist onlay does not have it has a short term, but doesn't have a long-term benefit. And if you look at all the randomized trials that have been done, this is a busy slide, but I'll take you through it pretty easily. So these are the authors for the randomized controlled trials of using mesh curl repair versus suture curl repair alone in randomized trials. And the bottom line is no significant difference in major complications, no significant difference in recurrence, and none in terms of reoperation. So the upshot of this is that using both synthetic and biologic meshes in a multitude of ways has not been shown to be durable over long term. And again, this is just another example of how we all struggle to solve a difficult problem. This in red is the one that we really adhere to. However, we use this one as well, and maybe this one as well. But one should never go 360 around. At least I don't. I don't like that idea. There's some evidence that I think from Nat Soper, where he looked at in a porcine model keyhole versus no keyhole, and found that if you go all the way around, you're going to have a much higher stricture rate. This one here, really avoid. That's just not going to work. This hard edge here is going to be rubbing up against the esophagus, and you're going to have a world of hurt trying to take care of that patient when they have a problem. And then finally, what are my bailout procedures? So I'm in, I see this huge hiatus. I'm trying to get it closed. I can't get it closed. The muscle's shredded. So what can I do? Well, one thing that we've employed, and particularly in patients who present with acute volvulus, the older 82-year-old female with kyphosis and maybe scoliosis, and she's sick. So in that patient, what we've started doing is a 2-point G-tube fixation. So we'll put 2 pegs in, one close to the greater curvature along the fundus, or close, just below the fundus of the stomach, and then another one in the middle of the antrum. And the idea behind this is to prevent recurrent volvulus, and we've had good result with it. And if they are sick, you can feed through it, or you can convert it to a GJ and feed them downstream or something like that. The thing that we've really gone to for our bailout procedure, and I kind of learned this from Jim Lukatich, who I think more and more has been using this approach as opposed to trying to do a fundoplication, is really doing an extended gastropexy with an angle of his reconstruction. So we suture about on the greater curvature of the stomach, about 2-3 centimeters distal to that, gastric fundus to esophagus to the pillar or the base of the left crus. And then we just carry the greater curvature up on the diaphragm with multiple sutures all the way down onto the abdominal wall and then onto the antrum. And we've had good success with that. So in conclusion, we close the crura posteriorly and use adjunct techniques as we described here in this talk. We use relaxing incisions as kind of our back pocket procedure when we have a problem or we just can't get it shut. We give that a try. And I'm excited to go back. You know, we've done several of these now, and I'm excited to go back and take a look. But I really don't. I haven't had to reoperate on any of these patients, but I'll be interested to see what our results are. You know, keep in mind that, you know, we have not solved this problem. You know, we reoperate on these patients frequently. Our follow-up esophograms at 1 year show the typical small recurrent hiatal hernia in about 40%, the majority of which are asymptomatic. Remember that most experts don't recommend using permanent mesh, and we avoided in and around. What I mean by this is in and around the esophagus. We keep it away from the esophagus if you're going to use that. And the use of biologic mesh is safe and associated with short-term benefits. However, long-term results do not show a reduction in prevention. So thank you very much for the opportunity to be with my friends and to present some of these ideas.
Thank you so much. It was a very, very, very interesting lecture. And I'm pretty sure that you give answers to a lot of questions from the different participants, because already yesterday we had a lot of questions regarding the crura repair, the diaphragmatic hiatus, etc. So I will just go to Maddie and Rita to see if you have again the same issues with the participants.
Thank you for the amazing lecture. Maybe we will have first the poll. So look into the experienced audience. And here we have, if you cannot get the hiatus closed, I do the following as the first option. Relaxing incision of the diaphragm, I open the pleura, or I perform a bridging closure with the mesh. Please feel free to vote. And meantime, we will ask an interesting question of, I will see the name, of Paulo Roberto, that is asking, how can we suspect a very wide hiatus before surgery? How do you realize it's going to be really hard to closure? Do we have any preparative CT scan that can allow us to recognize it?
I think, you know, you can't. You know, it's kind of funny in our clinic, you know, the fellows will always come up and say, this patient's got a really big type 3 hernia. And I'm like, they're all big, you know. So it's not really until you get into the operating room that you can really determine. I guess, you know, if a patient has a type 4 hernia, that is, they have some element of viscera. In addition to that, you can expect that they're going to have a very wide open hiatus where everything's thinned out anteriorly and posteriorly. So if I see, you know, pancreas or spleen or transverse colon or something like that in the chest, then I think you can anticipate that you're going to have a huge opening. And those are the toughest of the tough in my experience, outside of redo paras. So that would be the one way. I don't know if the other panelists have ideas about how to determine that preoperatively.
John, you have some ideas? You're using preoperative studies to try to evaluate the size of the hiatus and the difficulties?
Bernard, no, I think Blair said it well. I think probably the one predictor that I've seen for really woody, fibrotic, difficult crural closures are the redos, especially, as we say, the 3dos. If you're doing it the third time, it often is very difficult to pull them together because they're so fibrotic. But even the very big ones on your first go round usually can come together, I found.
Lee?
Yeah, I think they've said it well. I think it's less of a question of the size, which you can probably measure with a CT scan or an MRI if you want to spend the extra money. And it's more the quality of the crura. Is it so thin it starts tearing and you make it bigger as you try to close it? Or is it fibrotic and thickened?
No, I totally agree. Some hernias look ugly on CT scan. They're very easy to do, and some others look totally fine, and you think it's a quick case, and then you have a nightmare when you're trying to close. So.
Guys, do you have some tricks to evaluate the the consistency of the musculature, the texture. Can you say this is a good one, this is not a good one, by feeling it, by seeing it? Do you have some tricks to say this is going to be a bad repair because the musculature is not good anymore? Do you have some tricks for that?
Well, the ones that get really, really thinned out, those are the ones that just tend to tear apart if there's tension on them. And so for me, if I see a really thin crura, even if it's not inflamed or woody, that's the one that is really going to be hard. And you're going to be looking at a big hole on the medial and lateral sides of the repair as you pull it off of the pre-aortic fascia or pull it off of the insertions. So that's the one that I really get frustrated with.
Your opinion about that?
The way I tell Bernard is I put the stitches in and I tie them down, and when the right crew starts to shred, I say that was actually a very weak diaphragm, and there's my relaxing incision.
That's a good trick. And Lee, you have
Same thing.
Not really. I see people that actually grasp the two crews and try to pull it together. I think that's a bad idea. I think you'll just traumatize it. You'll crush the muscle fibers. So I think you can kind of tell if the texture is pale and abnormal looking. You have to be very careful if it's super thin. The one I won't let the residents or the fellows do themselves is when it's really thin, because I think that takes such delicate technique to not make things worse.
do the type of stitches that you are doing on the repair. So figure of 8, X, single stitch or whatever. Do that impact the quality and the survival of your repair? Or you can do whatever stitch you want, doesn't matter.
That's sort of my feeling.
Okay, John? Okay, Lee?
Yeah, I think, I don't think it matters what type of stitch you take, but I think it's a technical error if you over tighten those stitches, because you can strangulate the muscle fibers, which after all are parallel and the blood supply is parallel.
I would say exactly the same thing.
Okay. Yeah. So from the side of the participants, Ada? We
have here another question that is also related to the type of closure, because normally we do interrupted sutures. But here and yesterday they posed the question that if you have an experience with barbed sutures.
With?
Barbed sutures. To close it in a continuous fashion.
Continuous suture. What's your opinion?
We've tried that a few times. It's easy to do. I don't think it necessarily hurts anything. What we did is a primary closure and then use the barb suture to run down the front of it like a baseball stitch, just from top to bottom. But I haven't had any complications related to it, and it's easy to do.
Lee?
Never tried it.
No, I don't like it.
No. And a question, because we are from the other side of the ocean, so we're not used to play with the needle order, comment ça s'appelle? The endostitch versus suture, normal needle driver. What's your opinion? Because I know that a lot of people in the United States are using the endostitch. So does it make some difference?
I guess I would, let me jump in because I think Lee and Blair know my bias here. I just think it limits your flexibility. It limits your flexibility in needle orientation and needle size. And it's really not necessary. I mean, when we've done trials of experienced suturing, it's no faster. But again, for someone who's inexperienced with suturing, and that may actually help them.
Okay, I guess it's time for me to come out.
Sorry, Blair.
So John and Lee have essentially taught me everything that I know how to do, but The endo stitch is so damn fast, and we can really move, through doing it. So we do use it quite a bit. But that being said, I stay true to my roots, and we do teach the fellows how to suture intracorporally. And
Okay, so
You're not welcome on the West Coast of the United
we
States.
know everything about you, Blair. So Blair, thank you very much. It was a very interesting talk, and the discussion was also very interesting. Time is passing, so we will change a little bit the program, and I would just like to introduce John. The results of the poll. Maddie or Rita, can you comment?
Yeah, sure. So we indeed have a variety of audience. Yesterday, we have seen that about 50% of our viewers are considered, let's say, beginners in this type of surgery, and the others are more experienced. So when you see how they deal with a big hernia, is that, more than the half performs actually a relaxing incision. The pleura opening is only 3%, and bridging closure with a mesh is even quite a big number, it's 43%. So do you want to comment on that? Maybe it's
Blair has to comment on that.
Yeah, I think that you just have to be really careful when you start bridging, because what that does is it sets up a rigid edge for the end of that esophagus to push up against. So I would really only bridge. Maybe the participants who answered this were thinking about bridging the relaxing incision that was away from the esophagus. If that's the case, then that's fine. But if it's adjacent to the esophagus, you shouldn't be bridging it, because you're going to end up with problems.
Yeah, I think it's a very important message. So thank you, Blair. I hope that you're going to stay with us, and we'll move to John. So John is a longtime good friend, and I was mentioning he was past president of the SAGES, so a very prominent person in the foregut and oral surgery in the United States. John is today the elective vice president and CEO of Oregon Health Science University. I just got this information from Lee, because John is John for me, so it doesn't matter. And really, John, it's a very great pleasure to have you with us today, because I think that your presence is so important in this sort of topic. So thanks for talking about the problems that we have during this repair of paraesophageal hernias.
Well, Bernard, thank you very much. And Lee, it's great to see you, and it's great to see Blair. I feel like it's... So I'm going to share my screen here, and we'll get on with it. The slides now, can you hear me okay, Bernard?
They're coming, yes.
Great. So greetings from Portland, Oregon. We're on the west coast of the US, and that in the distance you see Mount Hood. That aerial tramway is actually how I get from the hospital to the clinic. It's not a ski lift. And so I appreciate the order being changed. In my role as CEO of the health system, I have a 8 o'clock huddle that I have to do. So I'm really sorry to have to leave you a little bit early. The old guy always gets to talk about the complications, so here you go. And I changed my topic a little bit to talk about complications of the hernia itself as well as the repair, because I know you probably had some very good talks yesterday, but I think there are some nuances here that are important. This is something we've been taking care of for a long time. I think Lee and I probably did the first paraesophageal hernia repairs together around 1990 or so. 1995, one of the first laparoscopic fellow, Margaret Oddsdottir, put together a series of 10 of these. And in those 10, we had a number of complications, and we realized that this was not an easy repair, even from the beginning. A couple of things about the complications of giant hiatal hernia. Initially, it was thought that all hiatal hernias, giant hiatal hernias or paraesophageal hernias, should be repaired on the basis of a single study that David Skinner did with Mr. Belzy on 29 asymptomatic patients that were followed for a decade. And 21% of them presented with strangulation, and almost 20% of those died with a lower mortality and elective repair. So they came to the conclusion that all giant hiatal hernias should be repaired. That was challenged by David Ratner and his team because he felt that gastric volvulus with strangulation is a rare presentation of a paraesophageal hernia. So they went back through all the published series in the late 90s, sort of the modern period, if you will, the laparoscopic period, and found that there was very infrequent emergency presentation, about 1% per year. The mortality of repair in the emergency situation was about 1/4 of that Mr. Belzy saw, or 5%. And the mortality of elective repair was, again, about 25% of the emergency repair, or 1.4%. So with those numbers, they could plug it into a Markov Monte Carlo analysis, took a 65-year-old asymptomatic patient, ran the simulation and determined that watchful waiting confers greater quality adjusted life years than repair. This was, of course, very sensitive to surgical mortality rates. And even since that study has been published, surgical mortality rates have fallen well below 1%. And in certain circumstances, it may be reasonable to think about repairing people with either no symptoms or very modest symptoms. But generally, this is the board answer for our questions today. I like to talk about this in the context of what does asymptomatic mean? Because frequently symptoms that are, or signs that are related to paraesophageal hernia may be overlooked. And the two that are most frequently overlooked are shortness of breath and anemia. And so I'm going to talk a little bit about both of those before we get into the surgical complications. So it is not infrequent that patients, about 30% of patients in our series who come in with paraesophageal hernias are anemic. And they may be anemic with a normal upper endoscopy, or they may be anemic because they have these things called Cameron's erosions. And you would wonder, without the evidence of bleeding, without the evidence of a true ulcer, how these are contributing to anemia. But the chronicity of them and the frequency with which they bleed and heal is probably the answer to this. These patients, of course, need a colonoscopy to make sure that there isn't a colon cancer before you fix their hiatal hernia. But I'll show you some data in a minute about how beneficial fixing the PEH is. One other caveat, this is a deeper ulcer. It's not really a Cameron lesion at this point, it's a Cameron ulcer. We had one of these perforate in the postoperative period because this is really, can be a full thickness. This could be fibrin sort of in the repair process. And so what I learned from that is if I see one of these big, deep ulcers, I treat them with PPI prior to surgery. And if you have something as deep as this, I would rescope this person to make sure they're healed before I operate on them, because I would be fairly concerned about perforation. Now, if you detect it intraoperatively, you can fix it at that point, but you may not. What about iron deficiency anemia? This is a study that Don Lowe did. And in his series, I said on our series, it was about 30%. In his series, it was 46% of patients had iron deficiency anemia. And 32% had Cameron's ulcerations. Again, that's a little higher than what we've seen, but that's a reasonable number. And after repair, 90% of them had an improvement in their hematocrit, 71% of the anemia was gone, and 3/4 they could discontinue their iron. So this does actually work. I want to take one other symptom that is, and that is shortness of breath. I love I do this resident conference, and our residents are on this morning. And a few weeks ago, I queried them as to why patients with PEH get short of breath. And the standard answer is it's compressing the lung. And then I said, well, why, if you do a pneumonectomy, are patients not short of breath? And that usually is a little bit silences the crowd. And I think for a long time, and really up until recently, quite a number of people attributed it to some sort of pulmonary dysfunction, but this is almost certainly cardiac dysfunction. And Greg Falk in 2011 did a very nice study where he looked at CT scans and echocardiograms of patients with giant hiatal hernias, and showed that in fact in this CT here that the hiatal hernia is compressing the left atrium. When it's repaired, the left atrium comes to its normal size. You can see it diagrammatically here. When looked at the post-op performance criteria after repair of giant paraesophageal hernias, the pre-op showed that there were a fair number of people who were class 3 and class 4. New York Heart Association post-op, almost all of those patients returned to the higher cardiac performance. So I think that really answers that question. Now, I think you actually asked me to talk about post-op complications, and the most common post-op complications I think have been dealt with by Blair and Steve and others in terms of esophageal length and closing the difficult hernia. So I just want to talk about a few of the acute post-op complications that and again, this may be addressed as much to residents as anyone, but in the patient who is immediately post-operative, if you're called by the nurses to see them because they're diaphoretic, dyspneic, uncomfortable, tachycardic, a host of things go through your mind as to, is this an MI, is this a PE? Those are the standard things to do. But this is one situation in which examining the patient is very helpful, because one of the rare but disastrous complications is an acute gastric dilatation. And you can diagnose this with an X-ray, as you see here, but most of the time you can actually diagnose it at bedside by just tapping on their abdomen and hearing the tympanitic upper abdomen and seeing the massive distension of the upper abdomen. And again, the treatment here is to put an NG tube down, a rush of air comes out, and the patient feels immediately better. So that's one thing that you need to be aware of. As I said, this is relatively uncommon these days, but I've seen enough of these that it's worth talking about. The other thing that's probably more common is that immediate post-op retching, the retching that will occur in the first 24 hours post-operatively, or even just you know, and most of these patients actually won't bring anything up. As you know, the valve prevents vomiting, so they'll just be straining. And they may or may not be uncomfortable, they may not be tachycardic, but if just the mere presence of that episode is sufficient in my mind to warrant an upper GI. And this is a patient who had an episode such as this, and the upper GI you see shows that the stomach is now again above the diaphragm. The treatment for that is to get the patient right back to the operating room. Often the wrap is intact, but we usually just take it down so we can inspect everything, the stomach, the esophagus, make sure that the active retching didn't tear holes in anything. And then we'll redo the repair, hopefully find out what we did wrong and fix that problem. Maybe make a relaxing incision, maybe lengthen the esophagus, a variety of things that you might need to do. And if you get it early, it's not that difficult to do. The other situation, which is not dissimilar, and in fact, I'm showing you the same X-ray because it could be the same patient, is other events leading to chest pain in the early post-op period. And I'll just give you three examples of patients who have done this in the early post-op period. I had a farmer from Nebraska. Nebraska's a big farming country, who went home and threw a bale of hay and heard something pop. He'd reherniated. An architect who went to visit a job and saw a stone lying in the middle of the driveway at the completion of the job, tried to lean over, pick it up, popped the suture, felt chest pain immediately. A young woman got home and coughed vigorously, caught a cold, and she popped out her sutures. So you know, anything that often people feel a pop, sometimes they don't, but if they have chest pain or discomfort in the post-operative period, you need to get this radiograph. Now, what happens if you don't? Well, if you delay, sometimes it looks like this. And this, of course, is gastric necrosis. And gastric necrosis that's associated with acute post-operative recurrent hiatal hernia and strangulation is treated with wedging out the dead stomach if you can. Unfortunately, if the GE junction or the gastric outlet is involved, you're going to have to take out the stomach and do a foregut diversion procedure and reconstruct later with colon or small bowel if there's enough esophagus to do so. So that's sort of the worst. So I'm going to finish with that to give a little time for questions. And just in summary, iron deficiency anemia, while not a symptom, is an indication for repair of a PEH. Shortness of breath associated with PEH is associated with cardiac in origin and does improve with repair. Post-op gastric dilatation is treated with an NG tube. Retching, straining, chest pain warrants an upper GI and urgent repair. And with early post-op recurrence or repair, with early post-op recurrence, you either re-repair or if there's dead stomach, you need to resect it. So that's all I know. Thank you very much, Bernard. And it's great to see you. Great to see all my friends.
Thank you, John. Silvana?
Thank you, John. I think that for me at least, I don't know for you, but calls for a long list of memories. I think that we have seen all of it. And
Good recap.
yes, a good recap of what you can see and what you should avoid and look for. And I'd like to know if we have some questions. I'd like to know also, because I know you prepared another question for the audience, and I'm sure it's going to be about MASH.
Of course. Yeah, thank you very much for the presentation. Indeed, we prepared another question, and because MASH was a very popular topic yesterday and today, we wanted to see the complications that our viewers have with the MASH. So we have a poll question about that, and that is, did you ever encounter a MASH erosion in one or more cases in your life, in your procedures? The answer is yes or no, just to see if the number is the same as in the tertiary referral hospitals. In the meantime, we have a question about the early complications. So, Professor, when you do a surgery, you have your patient in the ward. What is your regime for these patients before letting them going home? Is it the next day? What are the criteria to differentiate between a potential complicated patient and a patient that is going to be all right? Do you have any advice on that?
Yeah, thank you. Yeah, we usually still keep patients in the hospital overnight. That's sort of considered outpatient surgery in the U.S. right now, and it's done really just to observe them for the ability to urinate, making sure they don't have any of these early post-operative issues that I identified. And in most cases, it really depends upon the nature of the repair. I will fairly routinely get a swallow the next day if I've done a major repair, if I've done a cholecystoplasty. But if it's a really straightforward paraesophageal hernia repair and without difficult dissection, probably just let them start on liquids shortly after surgery. Send them home on a liquid diet for a week. There is a fair amount of edema, so if they try to eat solid food, they will get impacted, so it's really just an overnight hospitalization most of the time. And I didn't talk about mesh erosion. I probably should have in the complications, but yeah, mesh. As Blair said, bridging mesh is a bad idea. Encircling the esophagus is a bad idea. Both of those have led to erosions that have required gastrectomies or esophagectomies when they've been referred to us in distress. So those things probably shouldn't be done.
Thank you very much for these clear advices. So we look back at the results of the poll, if we can show them on screen, please. So indeed, the majority of no, not the majority, but about 40% did indeed see complications of the MASH. So I think it's a good question just to emphasize even more here that maybe using a non-absorbable MASH is not a good idea. Professor Peretta, do you want to comment on that as a take-home message?
I think it comments by itself. I think that whenever you can avoid MASH, you should avoid MASH. And I think that Lee and Bernard share the same thought, and redoing a case with an eroded MASH, either in the esophagus, the stomach, or in the small bowel, it's a nightmare. And you're lucky if you can keep the gut together. So I think it's a bad idea, but that's personal opinion. But I know that John needs to leave. correct? Because
Yeah.
you have,
I do. I'm just actually texting my team to say I was going to be a few minutes late. But so I'll take one or two more questions.
no, I mean,
No, I was very interested by the fact that you're still using some upper GI series on the next morning because we still do it. So we started 30 years ago, and systematically we're still doing swallow in all the patients at the first morning. Because if I start to do that in the past, it was just to show that we were doing good things when we start laparoscopy. And in fact, we've got a lot of information because you mentioned this acute herniation, and we've got patients without any symptoms, ready to go home. And when we check with the upper GI series, we find the stomach above the diaphragm. And I'm personally convinced that a lot of recurrence that are reported 3 months afterwards or 4 months afterwards were indeed early recurrence after recovering from the anesthesia. So that's why we're still continuing to do swallow in older patients. Do you have any comments on that, John?
Yeah, I think that's a great point. I guess thankfully we have seen very few asymptomatic recurrences. I can count them on one hand if we have. But I might just turn the question back to you and say, if someone's completely asymptomatic and they've reherniated, do you take them back to the OR that day?
Yeah, always.
Yeah, I think you should.
Always, because we know that
you say that.
If it's an acute one, the one that you show, you have to do it, even if they don't have yet symptoms. And even if you have a migration, the pop-up of the valve with, what we know is that with time passing, everything will get bigger and bigger and leads to symptoms. And when you have to redo at that stage, it's very difficult. When you redo the patient the next morning, it's very easy. So that's why we still continue with that. Yeah. Lee?
I think that's a great topic and a great point. And I think it emphasizes the importance of prophylactically treating these patients for nausea and vomiting, and to use anesthesia that's got the lowest risk of induced nausea and vomiting. So John, what sort of regimen do you use to pre-treat patients or treat them immediately afterwards?
Yeah, no, great question, Lee. And I think the first point of that is educating your anesthetists or anesthesiologists. And long ago we created a pathway with the antiemetic protocol that every anesthesiologist has in their hand. And it's based on Zofran, but they basically throw everything they have at them. Often we'll use, so that's on Dancitron, by the way. I don't know what it's called in Europe, but on Dancitron, they'll also use other standard antiemetics such as Phenergan or Compazine. I think propofol anesthesia has really helped a lot too. We don't always use propofol anesthesia, but I think they use a fair amount of it. So it seems to have really gone away, but I think it's only gone away because we recognized it and treated it aggressively up front.
I just have one feeling to share with you. Personally, I'm convinced that if you have a patient with severe nausea in the next morning, you should check him with X-ray, because in my experience, those patients do have a problem with the valve. And usually it's migration or paraacute herniation. So for me, the role of the anesthesiologist is to recover the patient properly and not waiting till the guy is having the tube in the mouth and starting to stretch to get this tube out. And they have to remove the tube immediately at the end of the operation. And this is really something that I've learned with Silvana when I moved from Belgium to France, when I got this sort of early migration, because in fact, here in France, they were sending the patient in the recovery room with the tracheal tube inside and waiting for the recovery of the patient. The patient was pushing, trying to get this tube out, and we got migration. So this is probably for me, the most important thing is to discuss with your anesthesiologist, looking at the way they are recovering the patient. This is probably one of the cause of these early migrations.
Yeah, a good point. And I think the other thing I didn't say, Lee and Bernard, is that we do leave them unscheduled on Dancitron for the first 20 until they go home. So we give it to them in the hospital. because it's really critical to decrease the nausea. I think I am going to have to go at this point.
Yes.
So
Yeah, we try to keep you with us.
It's good to see you, John.
Thank you, John.
good to see you. Take care.
Bye.
Bye. Have a great
Bye-bye. Thank
evening.
you. Thank you
in
so
France.
much.
Bye-bye.
Someone said hi.
Okay. Okay, good. Thanks.
Okay.
So I just wanted to add one other thing is I think what Bernard was saying is really important, which is surgery is a team sport. And you know, we've employed something called ERAS, which is early recovery after surgery, which is a protocol that you use up front, and it includes, you know, when they come into the preoperative holding area, they get gabapentin, they get some magnesium, and then we do carbo loading of our patients. So they use some of the, you know, that runners use when they're the distance runners use. It's called GU, and it's high in carbohydrate. By some miracle, we were able to get our anesthesiologist to let us give our patients that. And then the other thing that we do for antiemetic is intraoperatively we give them some steroid. So they get Decadron or some type of steroid that has been shown to decrease postoperative nausea. And then I think the wake up, you know, we always say, as Bernard was saying, you know, we say we want a deep wake up. So the fellow's responsibility is to be there to make sure that when they get that ET tube out, the patient isn't pushing up or bucking up against that, because that's where we've seen recurrences too, and that's a real problem.
Yeah, thanks.
Train the anesthesiologist.
Train the anesthesiologist. So question again, or we're moving?
We can move on.
We
Okay.
can move on. So last but not least, it's my great pleasure to introduce my partner here, Bernard Delman, who I had the pleasure to work with for the past 15 years. We survived each other for 15 years. That's a very long time. Bernard also, like all the pioneers that we had today, needs very little introduction. He was the first to perform a laparoscopic Nissen fundoplication and standardize the technique, but also you might not know that he was also the first to perform the first laparoscopic esophageectomy. And he's a great mentor, very patient, I can say. You told me everything I know, and I have the pleasure now to have Lee too. So I'm in a very good hands, I would say. He's going to talk about recurrent paraesophageal hernia.
Thank you, Silvana, for this nice introduction. And it was okay. These 15 years were okay. A little bit of white hairs, but it's okay. So recurrent paraesophageal hernia, it's a very sensitive subject. And this is the type, and then we were discussing how to select the patient or to imagine that we will get some problems with the repair of the hernia. And it's true that sometimes when you're looking at some pictures with all the bowel inside of the chest, you can imagine that you will be in trouble. So CT scan gives you some ideas about the difficulties, but not the clue regarding the crural repair. So when we're talking about paraesophageal hernia recurrence after a primary repair, this is a slide that we made with my fellows for a paper in hernia, and we look at the follow-up with objective follow-up. Means that we have some image of a recurrence, because in the vast majority of the paper that you're looking for recurrent hiatal hernia, it's based on symptoms, and we will see that symptoms doesn't mean anything. So if we want to talk about reality, we have to have at least objective, and you have upper GI series, or sometimes you can have endoscopy. And you see that when we're talking about this series with objective follow-up, we have recurrence up to 66%. And 66%, it's me. So I can talk about that. But there are some people reporting 0%, and we'll talk also about that. When we look, and I think that Blair showed these slides before, or John, is this randomized trials, suture versus mesh. And again, on the right side of the screen, when you look at recurrence, you see that there are also recurrence when you have a mesh repair. So the message is that mesh doesn't prevent recurrence. And as we were talking before, mesh can lead to serious problems. So again, when you think about using a mesh, think twice, because this is something that is extremely important. What we know also, when you look at the literature, trying to analyze the literature, look at the length of the follow-up. And this is a slide that I've taken from one paper that we published in Annals of Surgery back in 2011, looking at the incidence of recurrence that we observe in a series of 80 patients. And you see that with time passing, the incidence of recurrence hernia increases. And I think that's Lee yesterday who mentioned that John says that if you have patients who can reach 100 years, you will have 100% of hiatal recurrence. And this is true because if your follow-up is lengthening, you will have more and more recurrence. So this is a reality. And what we know also, and I think that Blair has shown this slide from the job of Oschlager and Blair and Lee, etc., on biological mesh with this difference between 6 months follow-up, and you would look at that and say, okay, it's clear that we need a mesh. Then you look at 5 years and you have no difference. So please, when you're reading papers, scientific papers, just look at the follow-up because that's a big difference. And also look at objective or subjective follow-up, which makes sense in the follow-up of this sort of hernia. So we know that we have a hernia. So what should we do? This is a very important question. And again, if I take back my slides, looking at the radiological recurrence rate that you can see on this screen, you can see here that we have up to 66%. This is our study. And you see that comparative to that, the percentage of reoperation is very low. 2 to 11%, and 11% is brand new, is from the team of Australia, Watson, who looked at a longer follow-up of their randomized trials comparing suture mesh and biological mesh, and you see that they have 11% of reduced surgery. So even if we have 66% of recurrence, doesn't mean that we have 66% of reoperation. This is very important. So how do we decide if we have to go for something or we just looking at the patient? So are we based on symptoms or are we based on this objective recurrence? This is very fundamental. And again, looking at our studies back almost 10 years ago now, you see that the size of a recurrence was less than 5 centimeters in the vast majority of the patient. So just imagine an 80-year-old woman having had the repair of a large hiatal hernia and ends up with a 3 centimeter sliding hiatal hernia doesn't mean anything. So this is the reality of recurrence in paraesophageal repair. And when we look at this impact, you see that we have 52% of the patients are totally asymptomatic, even with the recurrence. So I mean, no symptoms at all. And we can see that on the GCLI index, which is a quality index. So this is something that is very important. And in our experience, we had to redo 2 patients, one for dysphagia, overtight fundoplication. It was really at the beginning of the experience. We were not mobilizing the short gastrics. And we had 1 symptomatic recurrence that needs surgery. And this is, for example, the follow-up that we did in this study. So on the left part of the screen, you see the pre-op image. The slide in the middle is the next morning swallow. So we are always controlling, and you see a right position of the GE junction, no too much stasis in the esophagus. And the same barium swallow made 10 years afterward, you see this small sliding hiatal hernia. So would it make sense to redo these patients who is totally asymptomatic? No, this is very important. Another type of repair with a mesh, this was a quite popular mesh, I don't know if they call that from Bard, if I'm right, that creates this very well-shaped mesh for the repair of the hiatus. And you see 2 years, we have a migration, obviously, of part of the anteroreflex mechanism or the valve. And these patients had no symptoms. Of course, again, depending on the age, the conditions of the patient, we're not redoing this sort of patient. Same, Pledget's repair, 10 years. You see here the hernia is a little bit higher, but this patient has no symptoms. So you're not doing anything in this sort of patient. But if you have this with this huge migration or maybe paraesophageal herniation in the chest leading to dyspnea, probably this is the type of patient that you may consider for reduced surgery, again, based on the profile of the patient. And this is the more recent study from Watson in Australia, as I mentioned, looking at the long-term follow-up. And you see that they mention recurrence in mesh. T-mesh is a synthetic mesh, psoriasis, biological mesh, and suture repair also recurrence. And you see that there are different types of reoperation. Here it's a stent for perforation. Here it's acute hiatus herniation. And you see that this reoperation were done within 30 days after surgery. And this is the thing that John Hunter mentioned, this acute postoperative herniation. And this is, for example, one of our patients. I remember very well this very old woman who was having his hiatal hernia repair. And the next morning, and Silvana will confirm, she was sitting in a seat and saying, okay, I'm ready to go home. And we said, no, we're waiting the results of the swallow, gastrography in the swallow. And this is the picture that you can see. And there is a problem. You have this big bubble inside of the chest. You know that you have a problem. And just to let you know that when we ask our residents to call the radiologist to say what was the results, the guy said, there is no problem, there is no perforation, the gastrography descends well inside of the stomach. But as a rule, we are always looking at the x-rays by ourselves, and we saw this picture, which is clearly a paraesophageal herniation. And as John was mentioning, you have to redo this patient. And this is the redo operation, and you will see that if you're waiting too long, then there can be some trouble. I will try to make it work. Yes. So we're entering, and it's not a question of crura repair. You will see that the crura repair, there was a crura repair done with pledgets reinforcement, and you see this is tight. This is very tight. So it's not a problem of a too large hiatus or whatever. It's really something that push across the repair, and even to reduce the stomach. So you see the pledgets there. And to be able to reduce this stomach, we had to dismantle all the crura repair. So that's why I'm saying that this sort of accident occurs not when the patient is awake, but when he's recovering from surgery. It's a big high pressure from the abdomen that push everything inside of the chest. And you see that you have to reduce this patient because just imagine that you're waiting 24 hours, 36 hours, you will have the gastric necrosis that John has shown. So please check your patient, as John is saying. We still recommend to do X-ray because really this patient had no symptoms. And if you pick up this sort of complication, even in 1 out of 2,000 patients, you preserve the life of one patient. This is something that is extremely important. And what we did is that after reducing that, we repair again the thing. We look at the patient when she was recovering from surgery, and she did well years afterwards. So this is a very important issue. And when I showed the results of Watson, he has got exactly the same problem with early migration. So take care, watch your patient when you do this hiatal repair, no matter if it's a large one or a very large one or a small one. So again, the same team of Watson in Australia look at the outcome of the patient with asymptomatic recurrence versus patient asymptomatic with non-recurrence. And you see that they have a little bit more symptoms. They have a little bit more heartburn and reflux symptoms and using more PPIs. But you see also that the overall risk of progressing to revision surgery is less than 5%. So again, everything is based on the symptoms of your patient, the quality of your patient, even if you have different size of paraesophageal hernia recurrence. That's not the indicator for repair. Just look at your patient and the quality of life of your patient. So symptoms and objective recurrence are mandatory before going to redo surgery. And usually symptoms are nausea, vomiting, weight loss, dysphagia, chest pain, dyspnea, epigastric pain. These are very typical symptoms of severe recurrence. Heartburn, they can have a little bit of heartburn because the valve is a little bit slipped or whatever. So you just give PPI. But when they have this sort of symptoms, you have to consider some redos. And these are some pictures or typical pictures of this complex and symptomatic recurrence. When you have these huge bubbles inside of the chest, you know that probably there is some problem with the stomach that may lead to these symptoms. So what are we doing in that? So first is to get access. It's evident that today when we have patients having had open laparoscopic surgery, it's a little bit easy to get access to the G junction. Most important is the reduction of the hernia. So sometimes the first operator has reduced properly the hernia sac, and you just find the stomach that is going back inside of the chest. It's not easy, but you have to do everything to try to reduce this hernia, of course. But what we have seen in the vast majority of these patients with recurrent hernia, and this is the case for patients that are referred to us, is that in the vast majority, they have they still have a sac in place. So at the first surgery, they didn't have sac excision. And you see here in this redo, we're starting to dissect the sac. And sometimes it's not easy because it can be very adherent to the pleura. That's where you can sometimes open the pleura or resect the pleura. But you have to do things that should have been done at the first shot, means reduction and excision of the sac. This is very important because otherwise you will have a second, third, fourth recurrence. So this is something that is extremely important. And you see that progressively you can find this sac all over the mediastinum, and then you go to the systematic repair that Silvana has shown yesterday. And sometimes it's not that easy. You see, this is a patient having get a thoracotomy for paraesophageal hernia repair, and you see this huge recurrence. And again, if you look well, you see that the sac is still present. And again, so what we're doing, we're trying to check a little bit around. There are sutures everywhere, and our aim systematically for every redo that are not our first operation, we're always looking for a sac, and I would say that in 95% we find a sac. And even in this open thoracic procedure, you will see that we're finding a sac. And I can tell you that in this condition, it's not easy at all. Very important is always to have your landmarks. You see that we're looking at the pericardium because I remember one redo when I was looking at the coronary arteries. So I was in the pericardium. So you have really to be very careful when you're doing that in redo surgery because the cleavage plane are not so easy. So be very, very careful when you're doing that. And you see we're working around progressively to find this sac and to resect this sac from this huge mediastinal cavity. I remember very well this patient for different reasons, but one of the reasons is that this patient was had this acute migration quite early after surgery with total aphasia. So she was fed from, I think, 6 months with gastrostomy or jejunostomy because she couldn't eat, and we were waiting that she get a little bit more force. We diminished the inflammatory process to go back by surgery. And you see it's not easy at all. And you have to do it because if you don't do it, there will be another recurrence. So this is really the first rule for any primary repair or secondary repair. And John was mentioning mesh. This is a patient having a paraesophageal hernia repair with a mesh. And look at that. Look at that when you have to redo this patient and you have the X-ray on the left part of the screen. This is a huge recurrence. And this patient has fistulization because of erosion of the mesh inside of the lumen of the esophagus. And in this patient, we made a salvage operation, mixing endoscopy, transgastric surgery, etc. But this sort of patient will end up probably with either esophagectomy or at least esogastrectomy. So this is the result of a mesh put because the guy had a large hiatal hernia. So again, think twice before using a mesh when you're doing this sort of repair. And here the patient was totally aphasia. So you see that when we are inside of the mediastinum, we don't know where is the esophagus. So when you're dealing with this sort of complex hernia repair, you always have to have your endoscope next to you and using it all the time during the different steps of the procedure, because sometimes you don't know, you cannot recognize the tissue. And here we were looking for the esophagus and we couldn't find the esophagus. And in fact, the esophagus was totally compressed by the recurrent hernia. And we had a long time just to remodulate sort of an esophagus under the control of the endoscope. So the better is to try to do a good first repair, because when you come in this situation, you will see that can be very, very challenging. Then afterwards, you will demantle. If the patient has got a fundoplication, you just restore the normal anatomy of the stomach to make a point and say, okay, what can I do now for a good repair? And yesterday we've seen that with Lee Swanström looking at the length of the esophagus, which is very important, because if you have a very short esophagus, everything will go back inside of the chest. So this is a time to check the position of the Z-line and to know if you need a lengthening procedure or not. So we have seen that yesterday, so I don't want to comment on that. And then finally, you have to decide what to do. So the question that you have to ask yourself is why you redo this patient. And I mentioned what sort of symptoms, age of the patient, previous surgery, obesity, etc. So you have to consider all these different elements before saying, okay, I'm going to do this or this or this. And again, you see the gastric emptying studies sometimes are needed, the state of the esophagus, the fundus, etc. All are different elements that you need to take into account before deciding what you do. And then what to do. Maybe you do the same. You will do a crural repair and a fundoplication. First redo, why not? Because the tissue may be quite normal. It was a wrong first repair and you just do a good second repair. Maybe you have to demantle everything. Maybe you just do a gastropexy. We've seen that with a Blair. Maybe you have to do a gastric disconnection. So it means you disconnect the stomach from the esophagus and you put a Roux-en-Y. And sometimes you have to do esophagectomy. So there are a lot of different possibilities. And of course, I have no time to show you all the different possibilities technically, but you have to think before deciding. So if you have a difficult operation, bad stomach, bad esophagus, etc., don't try to redo the same operation because it will fail again. So you have to change something compared to the previous repair that has failed. If you're repeating a failed repair, you will fail again. And I like this because Blair has shown that the problem of tension everywhere, radial tension, axial tension, etc., is very important. And I just look at this slide from the team of the MIS in Los Angeles, and they compare their experiences primary repair. So it's not redo. They compare the first experience where you see they have a very high rate of recurrence by laparoscopy and a second period where they've changed a little things and you see that the rate of recurrence is totally not comparable. So, and I look at the different parameters they've changed to achieve this sort of results and use of that absorbable mesh. So they use it very frequently, not synthetic mesh, absorbable mesh, never used any synthetic mesh. More liberal use of a Colles gastroplasty. So again, we're focusing on the same question, axial tension, radial tension. So you have really to focus on that. And if you can reduce this tension, you can do the similar repair. If you can't do it, do something else, maybe gastric disconnection, gastropexy or whatever. And just to show you something that is quite significant because we know that it's not easy, so it's a patient with a previous open repair, and we're trying to dissect the sac from the mediastinum, and you see we're finding sutures everywhere. So you need a quite large experience to do this sort of operation. So we're trying to free the sac from the different attachments, looking at stitch. So we say, okay, we can cut it, and you control that. So you see that we are very high because you can see the pericardium. So we are really at the level of some important structure in the mediastinum, and we're still trying to continue to resect the sac, and you'll see that this is a problem. This is a problem because there we had the problem with the inferior pulmonary vein. So just to show you that in this redo, these can be very challenging operation. Conversion rate is of course very high. And in this patient we convert. We did a thoracotomy to control the inferior pulmonary vein. Mortality rate is subsequently higher. And the success, each time you're repeating this operation, is getting lower. So better to do is to do a very good first primary repair. And I don't know who says that once, but every effort should be made to retain the native esophagus when the process appears reversible. But so you have to keep in mind that sometimes you need to do esophagectomy. So thank you very much.
Thank you. Thank you, Bernard. Do we have any We do have a poll first.
Yeah.
And then
Thank you
we
very
have
much.
some questions.
If time permits, indeed, we have one poll question, and then we can do 2 clinical cases if possible. And one question is about adding more numbers to the numbers that you already shown, and that is about the recurrence rate of our audience. Could you please pick one of the options? How many recurrences do you see in your own hospital? So we can look at one of the cases that has been presented by colleague Edward Jaboa. It's about an 80-year-old female. She was operated recently. She had a large hiatus which could not be closed, so the surgeon did a fundal gastropexy. She had returned 4 weeks later with an intrathoracic stomach and a volvulus, and they are planning to do a new operation soon. The question is, what is your advice, and can you comment on this approach in general? Of course, we are missing some data, but in general, what can we do?
Lee?
Well, I think it's been known for a long time that gastropexy alone isn't going to prevent herniation. As Blair pointed out, usually it kind of fixes the stomach in position, so volvulus is kind of rare after that, but you probably have to do a very aggressive gastroplasty. Peg tube is a good alternative for that, but I think that just demonstrates the danger of that.
And what about the large hiatus, because it was not closed on the first time in an 80-year-old patient?
Blair, you have an idea? What would you do? So no repair the first time, just a gastropexy, rapid recurrence. What would you do?
You're muted.
You're
muted.
Your mic.
Yeah, I would go back in and try to avoid doing the same operation again. No, I think get everything back down in the abdomen. Maybe consider a releasing incision or something like that. I would just have to think on my feet. I mean, I think that's the key. Is you really have to get a lay of the land and find out what's doable. And that's part of the fun and the challenge of foregut surgery, I think, is that a lot of what you do has to be made in the operating room. So somewhat sidestepping your question, but the options are, a releasing incision, is the patient have functional swallowing at the time, prior to the reherniation? If they have a burned out esophagus, then maybe you're thinking about converting that patient to a minimally invasive esophagectomy, or Roux-en-Y if they have peristalsis. I think everything's on the table in that situation.
Personally, when I look at this story, for me, I don't know, maybe we'll have the answer from the surgeon, but this is a sort of case where the sac is still in the mediastinum. And you have this sort of pump that try to get everything inside, because you have negative pressure inside of the chest, you have a big cavity, and everything is going there. Positive pressure, negative pressure, big cavity, everything goes up. So if you want to prevent somewhere the new recurrence, you have to resect the sac. And as Blair is saying, then you find a way to close the hiatus, and then you do a good gastropexy, but nothing will get back in the chest. Mm-hmm. So my question to the guys who asked the question: think about the sac.
Right. Yeah, I think that's really important. When we say do a gastropexy or a bailout, it's not pulling the stomach down and doing that. You have to do the full dissection and get the sac out. That's critical.
Yeah.
All right, colleague Edward, I hope we have helped you with these comments. Good luck soon. We can see the results of the last poll, please. All right, so we have a recurrence rate less than 5%, which is said by 20% of our viewers. So I think that is really excellent, or maybe too excellent, but the average is around 10 to 20%. But again, that depends on your definition of a recurrence, as you have shown. I think we can move on to the next clinical case by Rita.
We present a 76-year-old female patient with a type 3 hernia. The patient is very symptomatic, and the manometry show lower esophageal motility normal, but the 90% of the contraction of the esophagus are impaired. So in this case, that can be a problem, the dysphagia. Do you advise a partial or a complete fundoplication?
I think even what are the symptoms of the patient? I think if she has a very big hernia, she can have dysphagia also because of compression. So I wouldn't worry about it. In this kind of patients, she's early, I would just do the Hiatal hernia repair and leave out the fundoplication or do a partial fundoplication, not because of the motility, but mainly because of the symptoms.
Yeah.
Yeah, I agree with that. Mm-hmm.
Yeah, I'd do a partial fundoplication. I think the population of type 3 paraesophageal hernias tends to be old and frail and thin. An aggressive fundoplication is not what they are after. It's not the main point of the operation. So
I agree, because probably some of these hiatal hernia are long-standing hernia, compressing the esophagus, impairing the esophageal function. So I think that you have a true impairment of the function of the esophagus that probably will not go back. So you better go for a light anti-reflux repair, but you have to do the reduction of the hernia, the dissection, but a little anti-reflux. Sometimes when we have patients without any fundus, we even do sometimes some sort of door fundoplication, so anterior fundoplication, because we can anchor on all the hiatus. So there are a lot of different options.
I also think as foregut surgeons, we need to separate out, the type 1 repair, type 1 hernia repair, where your job there is to do a fundoplication. And that's, what we call hitting the home run, right? Everything's buttoned down. It looks beautiful when you're done. But with paraesophageal hernia, it's just a completely different animal. And I think you have to change your mindset for those that just, do those primary paras, that at some time, you're going to encounter that patient where you're going to have to fall back a little and not hit the home run, maybe just a double or a triple, So it's just a different animal, and so you have to think differently.
I think that's an excellent conclusion, because in fact, when we had the introduction, we were saying that we're not focusing on GERD, but focusing on this challenging hernias. And what Blair just said is the evidence that we have not to consider that this patient as reflux patient. Is a totally different world. And on both sides, you have constraints, technical constraints, technical rules, technical steps that are critical. So I go to Silvana to make some conclusion about these sessions.
I think it was fantastic. I enjoyed it very much. I hope the audience did too. And I'm very happy to be among friends. And I hope to see you very soon. So we should do it again.
Yeah.
And maybe in person too, and not only virtually.
Yeah, but I told them that they're going to come. So
yes. And I'd like to thank also the AV team. I'd like to thank Rita and Mabdi. And
we
hope
can
you
show
guys,
the guys on the back.
Yes. If you guys, you can show yourself.
Show yourself.
They're hiding.
We have
here they go. Thank you very much.
Team, working behind
the scenes.
Behind the scenes, and this is very important. So Blair, thank you so much. I really enjoyed that.
It's great to see you all.
Yeah,
great to see you, Blair.
We will bring you here for sure.
Mm-hmm.
So, and for the audience, thank you very much. Yes.
Thank you. Bye-bye.
Bye, Blair.
And goodbye to everybody.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Bye-bye.